The patient is a 65-year-old pensioner who is fit and healthy, has a clear medical history, and has had some dentistry done before in his life. His main concern is the discolored upper front teeth and is hoping to have some of the crowns replaced. Apicectomy was done 1 year ago on endodontically treated teeth 1-2 to 2-2. This was to avoid the removal of posts placed on teeth 1-2 and 2-1. The patient has good oral hygiene and is interested to have his discolored 1-1 and 2-1 crown. Treatment options were discussed. The discolored teeth were not crowned and recorded as Vita shade A4. Treatment options include crowning of all 4 teeth from 1-2 to 2-2, veneers on uncrowned teeth, and endodontic whitening on uncrowned discolored teeth, followed by composites, in this case on the teeth 1-1 and 2-2. The patient was rather skeptical and would like to whiten the 1-1 only and use the 2-2 as a reference for shade change. The aesthetic limits of the treatment were explained to the patient before proceeding. Treatment protocol is consistent with the walking bleach technique with 35% of hydrogen peroxide. Radiographs obtained were evaluated to establish adequate endodontic seal and alveolar height of the crestal bone. The most critical factor is not to place the whitening material below the alveolar crestal bone and to seal the obturating material and protect the endodontic seal. All the restorative material must be removed to allow bleaching agent to contact the internal tooth structure for optimal results. Here, flowable composites were used to seal any margins of old restorations to prevent leakage of the whitening material placed. Here, an ultrasonic scalar tip has been used to improve the surface contact for the whitening agent to be placed in. The glass ionomer cement and cavet must be a putty firm enough to be rolled by the index finger and thumb. There it is placed in carefully into the orifice. At the same time, not closing the surface area of the tooth to be contacted by the whitening agent. As 35% hydrogen peroxide can burn soft tissues, a black mini tip to syringe is expressed to avoid contact with them. Sufficient depth is needed to create a layered seal of glass ionomer cement, cavet, whitening agent, and cotton pellet as agent reservoir, and followed by another 1 to 2 millimeters of thickness of the mirrored layer to assume a seal. The outer surface is finally sealed by resin-modified glass ionomer cement Fuji 9 and is packed by a moist cotton pellet. A layer of Vaseline is then placed to allow setting and hardening of the material. Occlusal clearance in protrusive and lateral trusive movements were made. Premature occlusal contact may fracture the provisional restoration, resulting in leakage and loss of bleaching material. The procedure was repeated 5 days later when the desired color was achieved. Another 10 days were given before restoration of the tooth was made. This is to allow the shade of the tooth to stabilize. provisional restorative material were then removed to the level of glass ionomer sealing material. The SS opening was rinsed and cleaned. The orifice is then later sealed with glass ionomer cement. In the future, should whitening needed to be done again, it is reassessed. The tooth is then restored definitively, in this case with composite resin of the matching shade, which is A2. There has been a jump of 2 Vita Classic shades, and the patient is extremely happy.